In 1959, Johnstone, Evans, and Bagel published a report in the British Journal of Anesthesia on their experience with the compound Cernal, an agent developed as a potent analgesic and anesthetic. In that paper, the authors concluded that, quote, Cernal is undoubtedly the most potent general analgesic agent which has yet been used in clinical medicine. Cernal, the trade name for phencyclidine, or PCP, was soon discovered to be unusable as a medical agent due to its side effects. It wasn't until several years later that a related compound to PCP was discovered that had similar cataleptic, analgesic, and anesthetic properties with fewer psychoactive effects. This drug was known as ketamine. I'm Angel Desai, physician, public health researcher, and JAMA Fishbein Fellow. On today's JAMA Clinical Reviews, we discuss the history of ketamine, its pharmacological properties, and some of its potential emerging clinical applications. After its discovery, ketamine was promoted primarily as an anesthetic in ambulatory, veterinary, and other settings. It was approved in the U.S. in 1970 and was often used as a field anesthetic during the Vietnam War. It was versatile and easy to administer, although its dissociative properties contributed to a rise in its popularity for recreational purposes. In 1999, ketamine became a federally controlled substance in the U.S., but has remained an area of interest for researchers across the medical field. We spoke with clinicians and investigators to explore some of the emerging and re-emerging uses of ketamine today. One of those is a physician at Sunnybrook Health Sciences Centre in Toronto.
My name is Dave Yerlink. I'm the head of the Division of Clinical Pharmacology and Toxicology at U of T and a professor of medicine and pediatrics here.
Dr. Yerlink, let's start with the basics. What is ketamine and how does it work?
Ketamine is a drug that's been around for more than 50 years now, and its primary mechanism of action is as an antagonist at receptors I don't think I even learned about in medical school, NMDA receptors. These are receptors that are fairly widely distributed throughout the nervous system, and especially in the dorsal horn of the spinal cord, where they have an important role in the transmission of pain signals, but also in the development of chronic pain. So what ketamine does is it blocks glutamate primarily at the NMDA receptor. It tickles a couple of other receptors as well. It has subtle effects on GABAergic receptors and various subtypes of opioid receptors.
How do you use ketamine for pain?
Different docs will give you different answers to this. Ketamine has quickly, for me, become a first-line therapy for almost any kind of pain. I'm especially fond of it for patients whose pain is neuropathic in nature, and I've seen some horrible pain from vasculitis just melt away with ketamine dosed cautiously in hospital. But to me, if you're thinking of giving the patient an opioid, what would be the argument against trying some ketamine? It might not help, but it might, and it might allow that patient to be spared an opioid in hospital. And if it does, I think in general that's a win. Any patient who's had an operation, any person who's come in with an injury, especially someone whose pain is of a neuropathic nature, I think these are all scenarios where we might entertain the use of ketamine, not because it's a perfect drug, but because it is just such an inherently safe drug at the doses we're talking about.
We've heard about ketamine mixed with other drugs and its detrimental effects. How safe is ketamine?
The reason I'm fond of ketamine is because it is such a safe drug at the doses that we're going to be using for pain. Like with most drugs, the side effects, of course, are dose dependent, but the primary side effects that we'll see with ketamine are its psychoactive effects. So the sort of the dissociative out-of-body experiences or distortions in visual or auditory or somatosensory perception. Sometimes at higher doses, people will get altered perceptions of self and time. But as I say, these are all dose dependent. Some people will become a bit agitated, some will get a bit nauseated, and there are sometimes subtle effects on memory or reduced mental sharpness or verbal fluency, but those are typically pretty short-lived. The higher doses, again, the 0.5 to 1 mg per kilo and higher, are the doses where you might see an increase in heart rate or hypertension or palpitations, or in people who use the drug recreationally, which is one of its other non-medical patterns of use. One thing I also have seen, and this is more in people who have used it chronically and recreationally, is its effects on the genitourinary system. So it seems to cause some inflammation of bladder epithelium, and on cystoscopy you can see erythema and edema. But I don't think that's much consequence with short-term use, but with long-term use it can really have devastating effects and cause, I've seen patients who've had, obstructive uropathy requiring urinary diversions as a result of long-term ketamine abuse.
When using ketamine for acute pain, how is it dosed?
Yeah, I think it's a general principle with all drugs is start low and go slow. When I prescribe ketamine, it's generally intravenously, and it's either through an intermittent IV infusion. So again, zero point 0.1 to zero point 0.2 milligrams per kilo over 15 minutes. Some people go to 0.3, but I think anecdotally you get more side effects and not a whole lot of extra benefit at 0.3. So I might say, I might give 10 or 15 or 20 milligrams of ketamine over 15 minutes several times a day, or start a drip at 10 milligrams an hour and titrate that up to the patient's response as a continuous infusion in hospital. If the pain was more severe, I'd probably combine it with opioids and use it at a higher dose. But again, it's very patient dependent.
How can ketamine be administered?
So it can be given by nasal insufflation, and in fact, it's been used on the battlefield in exactly that way. It can be given rectally. I think it can even be given topically. I've used it occasionally. Some people will use it orally in doses of 0.5 to 1 milligram 2 or 3 times a day. Anecdotally, it doesn't seem to work quite as well when given by mouth. It's 25 to 30% or so of it's absorbed. It doesn't have the same sort of rapid onset of maximum concentration as it would when you give it intravenously. But again, it's sort of hit and miss. As a short-term adjunct in patients with pain, I'll sometimes use it, say 30 milligrams 2 or 3 times a day. Again, with the same rationale that, at least in the short term, over the span of a 4 or 5 day hospitalization, it's unlikely to harm the patient, and it might help their pain, and it might help me avoid using opioids or using the same dose of opioids. The multimodal approach, targeting different receptors with different drugs, is often very effective.
In the U.S., we are currently in the midst of an opioid epidemic. How does ketamine fit into this landscape?
One of the reasons why we are having this discussion and thinking about drugs like ketamine is because we've seen the consequences of an uncontrolled national experiment with opioids. They are very valuable drugs in the right patient. But as the doses go up over months and years, as they tend to do, we very often create more trouble than we intended to. Ketamine is also useful in chronic pain too. So at least in patients with chronic pain. So one thing I'll often see is someone who's on chronic opioid therapy, and maybe they're on high doses of opioids, although we see fewer patients like that than we did, say, 15 or 10 years ago. And one of the things that ketamine seems to do for some, but not all of those patients, is lessen opioid tolerance, that sort of the progressive need for higher doses over time. You view it as a little experiment, and you view it as one of the tools that you might use in managing pain. And you think of its safety profile compared to NSAIDs, which in the wrong patient can cause a lot of trouble, and opioids, which have side effects that we sometimes don't even recognize. I think ketamine is quite versatile and can be used either on its own or as an adjunct with those other drugs, with the intent of really helping the patient not just feel better, but get up and move around and get out of the hospital.
When I was in medical school over 10 years ago, we weren't really talking about ketamine in this way. What would you tell trainees about using ketamine for pain today?
When I ask a medical student or a resident, they come to me with a patient who's got, I think of one case in particular that sticks in my mind, is an older person who came to hospital with a terrible lumbar radiculopathy and wasn't able to walk. And the resident's inclination was to use some hydromorphone, which I don't think would have been wrong. But I said to him, so what are you trying to do? And he said, well, I'm trying to relieve her pain. And I said, that's fair. What else are you trying to do? And he said, well, I guess I'm trying to improve her ambulation and improve quality of life and maybe limit the time in hospital. All very sensible answers. But then I said, what are you really trying to do? And I could see the face crinkle up, because it was clear that there was a trick question. It wasn't really a trick question, but I was asking him to think from 36,000 feet. I said, why not just give 10 milligrams of IV hydromorphone? And he said, well, he immediately invoked the side effect angle. And so the purpose of that discussion, and I think doctors don't think about this enough, we tend to focus on the benefits we're seeking, and we only sometimes think about the side effects. And so what you're really trying to do, and this sounds so facile, it doesn't even need to be said, but what we're really trying to do whenever we're treating pain is we're trying to deploy a therapy where the benefits exceed the harms. And the reason why I think ketamine deserves a more prominent place, especially in hospital practice, is because it is so incredibly safe at the doses we use for pain. You've sort of automatically stacked that experiment in the patient's favor, right? It might not help. You don't know until you've tried it, but it's unlikely to hurt at 0.1 or 0.2 mgs per kilo.
Apart from analgesia, ketamine is increasingly being investigated for other potential applications. In March of 2019, the FDA approved nasal ketamine for treatment-resistant depression. The research remains ongoing in this area, and as always, longer-term trials need to be developed. We spoke with Dr. John Crystal, chair of the Department of Psychiatry at Yale and investigator at the National Center for PTSD and the VA Connecticut Healthcare System. He told us about ketamine as a potential therapy for treatment-resistant symptoms of depression.
We began testing ketamine in the 1990s because if used in very low doses that are too low to produce anesthesia, it has remarkable effects on consciousness, on cognitive processes, and those effects were of interest to us because in some ways they mimicked the signs and symptoms of people with psychiatric disorders like schizophrenia. And we thought we could use ketamine to probe, in particular, the role of the NMDA glutamate receptor in the biology of depression.
My understanding is that when you administered ketamine, the results were actually quite striking. What happened then?
We found the usual effects on cognition and emotion associated with the administration of ketamine to healthy people. In other words, people had transient distortions in cognition and in perception and emotion. And those symptoms went away very rapidly within an hour or so of drug administration, maybe 2 hours. But several hours after the acute effects of the drug went away, essentially when the drug was no longer at meaningful levels in people's bodies, people with depression began to report feeling a little bit better. And by 24 hours, remarkably to us at the time, some of the people felt that they had fully recovered from their depression episodes. Now, the effects from a single dose were not permanent. Eventually, everybody's symptoms returned. Some people rather quickly after a few days, others not until several weeks. But it was remarkable that this very short-acting medicine, ketamine, could produce such long-lasting and rapidly appearing antidepressant effects in these patients. And it's since become very clear that many of the people who respond very favorably to ketamine have not responded to other kinds of treatments that are standardly available. So that this medication, even a single dose, can sometimes produce a dramatic improvement even in patients who've tried many, many other different kinds of treatments for depression. And that those effects can be sustained by periodic administration of ketamine. And generally the way that we administer ketamine is 2 doses in the first several weeks. In other words, 2 doses per week for the first 3 or 4 weeks, and then tapering down to 1 dose per week.
Earlier in the program, we heard Dr. Yearling talk about the safety of ketamine when used for pain. How safe is it when using it to treat depression?
Ketamine is a very well-known medication and a very safe medication as long as it's used in the way that it's prescribed. So generally speaking, when people are receiving ketamine as a treatment, the main things we watch out for are to make sure that they're having a good subjective experience while the drug is in their system. But also, ketamine can raise blood pressure a little bit. It can produce, in some people, some nausea and vomiting. And we have ways to manage those side effects of ketamine pretty effectively. We can give a pretreatment with a low dose of ondansetron to manage the nausea and vomiting. and we can give a low dose of a beta-blocking medication like propranolol to prevent the blood pressure increases if necessary. Usually the nausea and the blood pressure changes are so modest and so brief that we typically don't pre-treat with any medication before giving the ketamine.
Can you tell us more about potential concerns around increasing access to ketamine and its addictive properties?
I'd say there are two issues about the idea that people would be using ketamine by themselves at home, perhaps with nobody else around. And some people find the effects to be very scary. And if someone is around, a professional is around, and can provide reassurance, these symptoms are very tolerable, and people generally can accept reassurance and tolerate the symptoms quite well. But if nobody's around, they can get quite frightened. And I wouldn't want that to happen to people who are seeking help for their depression. The second part, the euphoria-related part, is that some people find the effects of ketamine to be a little bit like having a lot to drink, somewhat like alcohol, or like nitrous oxide. And people who find those effects pleasurable and who seek it recreationally, that's a concern. But actually, it's not the main concern when used clinically. And the reason it's not the main concern is in the people that I've seen who were given ketamine to use at home, it wasn't that they were seeking to get high. The problem was that they were not confident about their own recovery. Just because you get ketamine doesn't mean you're protected from having bad days. And ketamine is not, as an antidepressant, does not produce a persisting state of euphoria, and it does not produce a lasting improvement of mood in people who do not have major depression. It only attenuates or reverses some of the underlying biology of depression. But what happens to some people who were given bottles of ketamine by their doctor to take home is that instead of spacing their doses of ketamine farther and farther apart over time, when they would have a bad day, they would take an extra dose of ketamine. When they anticipated something stressful happening, they take another dose of ketamine. So instead of taking one dose of ketamine a month, like many of our patients do maintained on treatment, they developed habits where they were taking more and more ketamine to try to protect themselves more and more from depression. But the problem is if you take it very frequently like that, instead of reducing your propensity for depression, ketamine can increase your propensity for depression. So because ketamine is not a drug like Valium that you can take every day, but instead a drug where the frequency of administration has to be very carefully regulated, we really don't want people to be taking lots of ketamine home. We want to control the administration of ketamine in the clinic.
Dr. Crystal, what are the recent developments surrounding the clinical use of ketamine?
The FDA has approved ketamine only for the treatment of what are called treatment-resistant symptoms of depression or treatment-resistant subtype of depression. And what that basically means is, generally speaking, people that we consider for ketamine treatment have failed at least 2 different antidepressant trials. And generally, we look for those 2 antidepressant trials to include different types of antidepressants. We want the trials to have been of a reasonable dose and for a reasonable duration of time so that we have a sense that a person really has not responded to standard treatments. Now, it turns out that many subtypes of depression fall into this category. The rates of treatment-resistant depression are pretty high. So they may have a bipolar disorder associated with depression. They may have an anxious depression. A lot of anxiety features are often a predictor of poor response to standard antidepressants. They may simply, for reasons that we don't understand, fail to achieve an adequate response to the antidepressant medications that they've received. And generally, after being treated with 2 or more good trials of antidepressant medications in combination, oftentimes they've also been treated with a second-generation antipsychotic medication like quetiapine or aripiprazole on top of their standard antidepressant medications. after people have gone through these several trials, there are a few good options that have a very high rate of clinical response. There was a large antidepressant study called STAR-D funded by the National Institute of Mental Health, and shows that by the steps 3 or 4, after you try 3 or 4 different medications alone and in combination, that the chances of any of the usual medications producing an antidepressant response are in the 10 to maybe at best 20% range. So for these patients who have these treatment-resistant symptoms of depression, there are only a few treatment alternatives that have a high probability of producing clinical benefit. One of them is electroconvulsive therapy, and this involves giving an anesthetic at an anesthetic dose. In other words, the person is asleep and they get the medication to paralyze them, and they're intubated, and then they have an electrically induced seizure for an adequate duration of time, and they have a number of episodes of these electroconvulsive therapy treatments. Electroconvulsive therapy, or ECT, is certainly one of the gold standard treatments that we have that are very helpful for many patients with treatment-resistant symptoms of depression. However, ketamine, which is a much less intense intervention, we don't intubate people, we don't anesthetize people. It's a low dose of the medication that produces relatively modest effects, but has the same kind of power or efficacy in helping people who have these kinds of treatment-resistant symptoms of depression. And what's really remarkable, I think, about the trials with Spravato, the S-ketamine conducted by Janssen, is that if you take people who respond to the combination of a new antidepressant medication plus ketamine, and then you look at how they are over time, if you don't continue the ketamine episodic administration, but you maintain them on this very new antidepressant that they've been treated with, their relapse rate over the next year will be over 50% in the Janssen study anyway. Whereas the relapse rate over a year, if they stay on the medication, is only about 25%.
It seems like the effects are really remarkable. Can you dive into that a little bit more?
So what's striking is that in the initial response to ketamine, instead of 10 to 20%, the response rate to ketamine is somewhere between 50 and 75%. And in terms of prevention of relapse, instead of expecting a relapse rate of somewhere between 50 and 75%, if they stay on ketamine, the relapse rate's about 25%. So you have a drug that is producing strikingly high rates of response in patients who have a history of a very poor clinical response to antidepressants. And not only is it producing this clinical response, but it's able, through episodic administration, to sustain a good recovery for long periods of time for a large number of patients. It's kind of remarkable because the last fundamentally new medication that was introduced for the treatment of depression was probably the tricyclic antidepressants, SSRIs being a refinement of the tricyclic antidepressants. And the tricyclic antidepressants were discovered in 1957. So it's been a very long time since psychiatrists have had a kind of a fundamentally new way to treat patients with depression, particularly these treatment-resistant symptoms of depression.
In today's podcast, we heard about 2 uses for ketamine: pain control and treatment-resistant depression. In the last 50 years, ketamine has seen many ups and downs, but ongoing research is uncovering new potential uses for the drug. It's an important tool that some clinicians are using today and may prove to have wider applications into the future. That wraps up this episode of JAMA Clinical Reviews. Thank you to both of our contributors, Dr. Dave Yearlink from Sunnybrook Health Sciences Center in Toronto and Dr. John Crystal from Yale University. For more information, you can follow us on Facebook, Twitter, and Instagram. For more content, subscribe to JAMA Clinical Reviews on Apple Podcasts or wherever you get your podcasts. If you have a minute to rate and review our show, it would really help us know how we're doing and makes it easier for other people to find us. This episode also has CME with a brief quiz. To get all of our JAMA Clinical Reviews content and CME, check out the JN Listen app in the Apple Store. You can also check out JAMANetworkAudio.com. A special thanks to Lisa Harden for scheduling our guests. Today's podcast was produced by Jesse McQuarters. Our audio team here at JAMA includes Daniel Morrow, Ed Livingston, Deputy Editor for Clinical Reviews, and Mike Berkowitz, the Deputy Editor for Electronic Media here at the JAMA Network. I'm JAMA Fishbein Fellow Angel Desai. Thanks for listening.